Good morning. I am Prof. Iman Abdessalam Ibrahim. I'm delighted to start with you the chapter of joint and bone pathology. Let's start the first lecture. ILOs of our first lecture. By the end of this lecture, we will define 3 important hereditary bone diseases, including osteogenesis imperfecta, achondroplasia, and Paget disease of bone. Also, we will define 3 metabolic bone diseases, including Rickets, osteomalacia, and hyperparathyroidism. Those diseases will be studied regarding the definition of the disease, the pathogenesis, the morphology, including gross and microscopic features, clinical picture of the disease, and various complications. Before studying those various diseases, we should first revise the anatomy and histology of the normal bone. Actually, we have 2 types of bone inside our body. One is the flat bone and irregular bones, including, for example, the skull, the vertebrae, and pelvic bones. The second type of bones are the long bones, such as the bones of the limbs. Regarding the flat and irregular bone, it's exclusively formed of cancellous bone, which are formed of bone trabeculae, including bone marrow spaces, while the long bones are formed anatomically of epiphyses on both ends. In between the epiphyses and the shaft, there is what is called epiphyseal plate. Epiphyseal plate is formed of cartilage, and it's present obviously in the children and adolescents. It is the area responsible for gaining length in the long bones. It becomes completely ossified at age of about 21 years, after which the bones cannot gain any more length. The third part of the long bone is formed of shaft. Histologically, the epiphysis is formed of a cancellous bone, which is the same structure as the flat and irregular bones, while the shaft, it is formed of a bone marrow space inside the center of this shaft, lined by endosteum, then the lamellar bone, and covered from outside by periosteum. This lamellar ossified bone is supplied by blood vessels running in variably sized tunnels in what is called Haversian system. The major cell component of the bone is formed mainly of osteogenic stem cells that are the precursor for the osteoblast. Osteoblasts, which are the bone forming cells lining the bone trabeculae, when it comes at a resting position, it is called osteocyte. On the other hand, the osteolytic cell of the bone is called osteoclast, and it is a multinucleated cell. So, to summarize up the structure of the bone as a gross component, it is formed of a compact and a cancellous bone, and under the microscope there are two types of bone, one which is totally mineralized but may be lamellar in the mature form or woven in the immature form, and unmineralized, and in this case we call it osteoid. So let's start now listing and defining various hereditary bone diseases. The first disease we will talk about is achondroplasia. Achondroplasia is one of the hereditary bone disease. I should note that a word hereditary disease meaning that the disease code is carried on the genes of the patient, but it is not mandatory to be expressed at time of birth. So, achondroplasia, it is the most common form of dwarfism. It's an autosomal dominant mutation. The defect here is present in the fibroblast growth factor receptor number 3. This would inhibit the cartilage senses at the epiphyseal plates, so the long bones cannot gain length during growing up. That patient would complain of that their long bones are short and thick, leading to dwarfism, while their heads and trunks are not affected, as the skull and the vertebral bones are not affected by the disease. So the patient would have a disproportionate growth in between their limbs and the trunk. The second disease in this hereditary group is called osteogenesis imperfecta or brittle bone disease. It is also an autosomal dominant mutation, and the defect is present in the type 1 collagen, which is the major component of the bone stroma. Clinical picture implies the following. There are a lot of skeletal deformities. Why? Because those patients have recurrent fractures as their bones are so brittle and weak. Those fractures undergo healing process which is weak and incomplete, leading to multiple deformities. In addition, they have a misshapen teeth or abnormal teeth growth. Why? Because they have a dentine deficiency, which is deficient in collagen type 1 as an important component of the normal dentine. They have a blue sclera. Why? Because the sclera is deficient in collagen type 1 making the sclera translucent, and thus the underlying internal choroid can be visualized easily. Hearing loss, which is a conduction defect type of hearing loss. Why? Because there is abnormality in the middle ear bones. The third disease included in the hereditary bone problems is called Paget disease of bone, or another name, osteitis deformans. Osteitis deformans is first described by Sir James Paget, who was an English surgeon and pathologist, and thus the disease is named Paget's disease. Paget disease of bone, or another name, osteitis deformans, it is characterized by repetitive episodes of regional exaggerated osteoclastic activity and bone resorption. So, the pathogenesis of this disease is starting by overactivity of osteoclasts that lead to bone resorption. This is the osteolytic stage. The bone is eaten up. This will stimulate the osteoblast to build up the bone. The most important stimulator of osteoblast activity is increased osteoclastic resorption. So in this stage will be a mixed osteoblastic activity. But what is the predominant? Osteoblast. Osteoblastic activity is predominant, and thus more bone formation will overwhelm the osteolytic activity of osteoclast. Finally, there is an exhaustion stage of cellular activity, and just there is no new division of osteoblast, but there is a laying down of bone matrix, and in this stage it is called osteosclerotic stage. The net result will be a gain of bone mass. As we see here from this scenario, that there is an ongoing battle between two types of cells. One is osteolytic or osteoclastic cell that break down bone, and the other cell, on the other hand, osteoblasts that build up bone. This battle, this ongoing battle, occurs in a random fashion without a proper remodeling. Thus, the new bone formation is mosaic in shape, is not properly formed, and thus the newly formed bone, although it is more than normal, but it is weaker and brittle, more than or weaker than the normal bone, and thus reliable for multiple fractures and deformities. The cause of this disease is the presence of a paramyxovirus infection with presence of genetic factor predisposition in the form of activation of rank gene and inactivation of OPG gene. The viral infection is integrated or incriminated in production of interleukin 6 by osteoclast and production of macrophage colony stimulating factor by those macrophages. Both factors, interleukin 6 and macrophage colony stimulating factor, are highly stimulants for osteoclast to begin the battle by osteolysis. It is potentiated by activation of the rank gene. This rank gene is stimulator for osteoclastic activity. In addition, this activation is potentiated by inactivation of the regulatory gene called OPG. OPG is inhibitory for the rank receptor of the osteoclast. So rank now is highly stimulated without presence of regulatory factor that normally regulate the rank activity, resulting in overactivation of osteoclast that will begin the battle of resorption and reactive activation of osteoblast and laying down a mosaic brittle weak bone. As we see here, here is another photo. The arrows in the left photo is showing or pointing at the osteoclast with multinucleated cells, and in the right photo, osteoclasts are apparent inside the blue circles, while osteoblasts are apparent inside the black circles lining the bone trabeculae. Osteoclasts make or perform the osteolysis. Osteoblast will produce a woven bone, then lamella bone. Finally, a mosaic lines are seen and the bone marrow is replaced by loose vascular connective tissue. In this photo, we can see the mosaic lines in irregular lamellar bone trabeculae with cement lines with many osteoclasts present in the upper photo, and in the lower photo we can see the mosaic or lamellar bone with cement lines. This will form a very brittle, weak bone that's liable to multiple fractures. As I said before, that this disease may be a polystotic, present in more than one bone in the body. It occurs in 85% of cases. It may be also a monostotic. It occurs in 15% of cases, affecting only the tibia, only the femur, only the ilium, and so on. And as I said before, that there is a lytic phase starting this battle, formed mainly by osteoclast. Afterward, there's a mixed phase. Here appear the osteoblast beside the osteoclast with a loose connective tissue in the bone marrow spaces. Finally, there is a sclerotic phase with the formation of woven, then lamellar bone with formation of cement lines. The clinical picture of Paget disease: if the long bones of the legs are affected, there will be a bone pain, bowing of legs, and multiple fractures. If the skull bone is affected, the patient comes complaining of enlarged head and headache. Sometimes they come complaining of that their old hats don't fit anymore because their heads become larger. In addition, there is a visual and auditory disturbances as a result of compression of the cranial nerves as they pass through multiple foramina in the skull. With overlying of excessive bone, this will lead to compression of those foramina and those cranial nerves. If the vertebrae are affected, there will be a back pain with nerve root compression, as the foramina of those nerve roots are narrowed and thus performing compression on those nerves. Also, there is a hypervascularity in the connective tissue, as those bones are in an ongoing battle of resorption and building up of new bone. Thus, they need more blood supply to perform the task. Thus, the patient would feel the skin overlying the affected bone is warmer than normal, and if the disease is polystotic, there will be increased demand for cardiac output and finally cardiac output failure. In rare cases, there would be a serious complication with a bad prognosis in the form of osteosarcoma. Why? Because there is proliferation and multiple division of osteoblasts, sometimes with a mutation and activation of the proto-oncogene, and final result of osteosarcoma. Treatment of those patients is performed by using a drug of bisphosphonates that interfere with bone resorption by reducing the osteoclast activity and induced osteoclast apoptosis, thus abort the battle from the start. This drug can abort the battle from the start. Here is the shape of the skull of Paget disease with head enlargement and dilated vessels in the scalp, and here is the skull of a dead person complained of Paget disease showing over sclerosis. We will shift now to the metabolic bone diseases. It includes Rickets, osteomalacia, and hyperparathyroidism. We will start by talking about Rickets and osteomalacia, which have the same core cause of defective mineralization of bone matrix as a result of vitamin D deficiency and phosphate depletion. The difference in between both diseases is the age of the patient. Rickets occur in children, while osteomalacia occurs in adults. To understand those diseases, we should first talk about the vitamin D metabolism. The major source of vitamin D is via ultraviolet ray exposure that converts the skin 7-dehydro or activate the skin storage of vitamin D into 7-dehydrocholesterol. Also, the dietary source of vitamin D is very important. Both of them will go to the first step activation in the liver and the second step of activation in the kidney to form the most active form of vitamin D. This most active form will perform the function via increasing absorption of calcium from the intestine and the kidney and maintain the normal value or ratio between the calcium and phosphate. This will help in activation of rank gene on osteoblast that binds to rank R on osteoclast precursor, performing proper remodeling of osteoid matrix, and production of calcium binding protein called osteocalcine. This is produced by osteoblast. This will help in binding the calcium from the serum into the bone matrix. To sum up, vitamin D metabolism from the sun rays and dietary sources will be activated in the liver and in the kidney to increase intestinal absorption of calcium and to save calcium from being excreted in the urine by activation of the tubules to reabsorb it, and increasing the bone mineralization by increase this osteoblast to secrete calcium binding protein called osteocalcine. In cases of vitamin D deficiency, there will be a drop in calcium level. This will stimulate parathyroid hormone production that helps returning the calcium level to normal, but on expense of phosphate level that is excreted in the urine. Thus the calcium phosphate ratio becomes abnormal. This will prevent laying down of calcium in the bone matrix, and thus mineralization of the bone will not occur. The functions of vitamin D is to stimulate absorption of calcium from intestine, also from the kidney, and help bone mineralization by stimulating osteoblast to produce osteocalcine, collaborate with parathyroid hormone to maintain the normal level of calcium in the blood by activation of osteoclast gene called rank R. Thus, defective mineralization of bone matrix result from vitamin D deficiency and phosphate depletion. What are the causes of vitamin D deficiency? It may be inadequate sunlight exposure, it may be dietary deficiency, malabsorption, liver or renal disease resulting in derangement of conversion of vitamin D into its active metabolite. Old age with a vitamin D insufficiency is. Thus, in cases of vitamin D deficiency, there will be hypocalcemia and compensatory parathyroid gland activation, leading to increased kidney function to reabsorb the calcium, but unfortunately on expense of phosphate. Thus, the calcium phosphate level will be abnormal in the bloodstream, preventing the normal mineralization of bone. On the contrast, it will mobilize the calcium from the bone by stimulation of osteoclast differentiation to maintain the calcium level normal in the bloodstream. This will correct the hypocalcemia, but will lead to hypophosphatemia and defective mineralization of bone. Pathologic features of Rickets and osteomalacia is the presence of excessive unmineralized osteoid matrix. The Rickets, there is a growing ends which is incompletely mineralized. Thus, there is a replacement of normal regular linear arrangement by abnormal proliferating disorganized. To understand the defect, we should first know the normal arrangement of cells in the epiphyseal plate, which is a resting cartilage that's stimulated by growth hormone to form a multiplying cartilage, then a maturing cartilage, calcification will happen, and finally conversion into bone. This will increase the length of the long bones. In Rickets, with a vitamin D deficiency and decreased calcium level, with reactive parathyroid hormone increase, with a derangement of the calcium phosphate ratio, preventing the normal mineralization of the growing osteoid, there will be defective mineralization of the cartilage, overgrowth of a cartilage in a disorganized form, and disintegration. This will lead to deposition of osteoid in an inadequately mineralized cartilage and disruption of orderly arrangement of the cartilage. This defective mineralization will lead to weak bones, microfractures with an abnormal capillary and fibroblastic bone. Here are two photos explaining photo number 1 is the normal costochondral junction with a normal arrangement of cells. In photo number 2, there is a derangement in the normal cells, thus they are disorganized and forming this nodular. Here are some features for a baby with rickets. First of all, there is a craniotabes. The baby has a weak skull bones that it yields under pressing fingertip. There is a frontal bossing. The forehead is widened due to traction of forehead muscles over a weak bone. There is a pigeon-shaped chest with rachitic rosary as a result of traction of the intercostal muscles over weak costochondral junction. There is a large abdomen due to lax abdominal muscles as a result of vitamin D deficiency, wide distal ends of bone, wide ankles, wide joints at elbow and wrist, all of those due to traction of the muscles over weak epiphyseal plates, bowing of legs and deformed spines as a result of inability of weight bearing with standard growth. Here are the rachitic rosary, pigeon-shaped chest, frontal bossing, widening of the waist, bowing of the legs, and vertebral deformity. A photo showing rachitic rosaries with horizon sulcus. Horizon sulcus is due to the traction of weak chest cage by insertion of diaphragm. X-ray showing widened metaphyseal ends, fraying meaning irregular of the surface, wide separation between metaphysis and the epiphysis as the epiphyseal plate is widened with a defective ossification of the epiphysis. Regarding the osteomalacia, it has the same defect of mineralization of osteoid, but already the growing plates are stable. So those patients, which are usually females during the childbearing period, with increased demands during pregnancy and lactation, thus vitamin D deficiency will lead to defective mineralization with bone pains, multiple fractures, but there is no or only bowing deformities. The deformities are not remarkable just in the vertebral column as a scoliosis, kyphosis, or lordosis. Let's start now the third metabolic disorder, which is hyperparathyroidism. First, we should understand the functions of the parathyroid hormone. It stimulates the osteoclastic activity by increasing the rank expression, leading to osteoclastic differentiation, and thus resorption of bone to maintain the calcium level in the serum normal. It stimulates tubular reabsorption of calcium on expense of phosphate excretion and increase the synthesis of vitamin D synthesis, thus stimulate the intestinal absorption of calcium. The causes of hyperparathyroidism, it may be primary cause as adenoma, hyperplasia, or rarely carcinoma, or it may be secondary cause due to renal failure, and in this case it is called renal osteodystrophy. The pathological features of hyperparathyroidism is increased osteoclastic activity resulting in bone resorption. The untreated hyperparathyroidism will lead to the osteoporosis, more severe in phalanges, in vertebrae and proximal femur. They called those lesions bound tumor. Why? Because the osteoclast dissect and tunnel into the central part of bone trabeculae, producing microhemorrhages which invite the macrophage to eat up those areas of hemorrhage, filling their cytoplasm with hemosiderin, giving the lesion brown coloration. Here are two photos. On the left side, this is the gross feature of the brown lesion with a cystic hemorrhagic mass, and on the right side there is a microscopic picture of osteoclast tunneling via the bone trabeculae and eating them. The upper photo is a low power for trabecular bone thinned and replaced by connective tissue with giant cells. The lower photo showing the magnification of the lesion with osteoclast, reactive multinucleate giant cells, hemosiderin-laden macrophage, forming a mass which was misnamed as a brown tumor. A radiograph showing two lesions pointed to by white arrows present in the bones of the hand with a verified bone trabeculae forming a cystic lesion, thus it's called osteitis fibrosa. Another radiograph for a patient with hyperparathyroidism with a cystic lesion in the lower end of the ulna and other lesions present in the small bones of the hand. Here are, to sum up, the hereditary bone diseases: achondroplasia, osteogenesis imperfecta, and Paget disease, and metabolic bones diseases: Rickets, osteomalacia, and osteotis fibrosa cystica. Regarding the causes, pathogenesis, clinical picture, and complications. Thank you for your attention.